Hello students. So today we'll be discussing about fibrinolytic agents. So basically what happens when there is a vascular damage or when there is an injury to the blood vessels. You've seen when we took the antiplatelets what happens when there is a cut in the blood vessels. What happens? The coagulation pathway gets activated and the final output of coagulation pathway is conversion of factor 2 to active factor 2, that is a thrombin. So this thrombin will convert fibrinogen to fibrin. Okay, so you can get fibrin strands like this. And into this fibrin strands, what happens? The platelets get aggregated because when there is an injury, the platelet will also get activated. So the platelets come to this side. Along with that, the blood cells also come and together they form the clot. Okay, so this is what normally happens. So once the cell damage is repaired, this clot has to get dissolved. And this process of dissolution of clot is what is known as fibrinolysis. Okay. So how does this fibrinolysis happens? The endothelial cells, the blood endothelial cells, they release something known as tissue plasminogen activator. So as a term itself, what does it do? It activates the plasminogen. So it converts plasminogen to plasmin. Now what does this plasmin do? It will cut the fibrin into fibrin degraded products. So without this base work of this fibrin strands, if this fibrin strand is cut into fibrin degraded products, the clot gets dissolved. So that is how normally the fibrinolysis happens. That happens in the body at a very slow pace. Okay. Now what happens when you are giving this fibrinolytics? This process is accelerated into at a faster rate. So what are fibrinolytics? Drugs which lyse the clot or recanalize the occluded blood vessels are called as fibrinolytics, otherwise known as thrombolytics. Okay. How does they act? They act by activating the endogenous fibrinolytic system. That is, they catalyze the conversion of plasminogen to plasmin so that the fibrin gets degraded to fibrin degraded product. So they does this by activating the tissue plasminogen activator. So this is the basic step. Plasminogen is converted into plasmin. So this step is activated by fibrinolytic agents, whereas those agents which inhibit this step are called as anti-fibrinolytic agents. Okay. So plasmin will convert fibrin to fibrin degraded products. Is that clear? The mechanism of action of fibrinolytics, otherwise known as plasminogen activators, otherwise known as thrombolytics. So they convert plasminogen to plasmin, and this plasmin will convert fibrin to fibrin degraded products and helps in dissolving the clot and thereby recanalizing the occluded blood vessels. Clear? Now a question can come. Why should we activate tissue plasminogen activator? Why can't we just give plasmin as such? The problem with giving plasmin as such is it gets immediately neutralized by the circulating antiplasmins. So you can see here, this is the endothelium. The endothelium releases its tissue plasminogen activator that converts plasminogen to plasmin, and the plasmin will cut this fibrin strands to fibrin degraded products. But soon after that, the plasmin gets degraded by the antiplasmins that are present in the circulation. Okay, so that is why we are giving agents to stimulate the tissue plasminogen activator. Now coming to the examples, we can divide them as first generation, second generation and third generation. The first generation we have streptokinase, urokinase. Second generation you have anistreptase, altiplase. Third generation reteplase and tenecteplase. One mnemonic which you can use is Surat. Okay, streptokinase, urokinase, reteplase, anistreptase, altiplase and tenecteplase. Okay, so this is how you can remember the examples. Now we need to briefly know about each of these agents. So first we'll start with streptokinase. So any guess from where do we get the streptokinase? It is from beta hemolytic streptococci. Okay. It is a protease enzyme What does it do? It forms a complex with plasminogen, exposes its active site and activates plasminogen to plasmin. So it has to first form a complex. It is not a direct plasminogen activator. It first has to form a complex and that exposes the active site and activates other plasminogen to plasmin. The problem with streptokinases, it is fibrin non-specific. It binds not only to the fibrin-bound plasminogen but also to the circulating fibrinogen or circulating plasminogen. So what is the problem with that? It can lyse the physiological clot and can produce a lytic stage in the body. So what will the patient suffering from? There is an increased risk of bleeding because of the lysis of the physiological clots. Okay. Now, another problem with streptokinases, since it is derived from beta hemolytic streptococci, and all of us know that all of us would have at least had one incidence of streptococcal infection, either in the form of tonsillitis or upper respiratory infections. So, all our bodies contain the anti-streptococcal antibodies. So, when you're giving streptokinase, a majority of it is destroyed by this anti-streptococcal antibodies. That is another problem of giving streptokinase. The T half is around 30 to 80 minutes, and since the antibodies develop, we cannot re-inject the this agent within 1 year. Okay. Now, main side effects, as I told, it is non-specific, fibrin non-specific. It binds to both fibrin-bound plasminogen as well as circulating plasminogen. So, bleeding is a major risk. Then, since it is derived from beta hemolytic streptococci, it is antigenic. So, allergic reactions can be there. The patient can develop hypotension, arrhythmias also. The only advantage, or the main advantage I should say, of streptokinase is its cost. It is relatively least expensive. Okay, but compared with the recombinant agents that will come in the coming slides, these agents are the streptokinase is the least expensive among the whole lot. Okay, so that is about streptokinase. So next, so important points about streptokinase is it is derived from beta hemolytic streptococci. So it is antigenic, so allergic reactions can be there and antibody developments can be there. So we should not re-inject it within 1 year, and it is fibrin non-specific, so there is a risk of bleeding. And the advantage is its cost. It is least expensive. So these are the salient features of streptokinase. So next we come to the other first generation first generation fibrinolytic agent, that is urokinase. So from the name itself, you know how from where does urokinase develop? It was first isolated from human urine, hence the name urokinase. Okay. Now we produce it from cultured kidney cells. So since it is obtained from human urine, it is not antigenic. So there is no allergic reaction. That is one advantage. Another advantage is it is a direct plasminogen activator. Unlike streptokinase, which initially has to form a complex to expose its active site, urokinase has direct plasminogen activating property. It is not antigenic, but this is also fibrin non-specific. It can be used in place of streptokinase, but more expensive compared with streptokinase. Okay, SK stands for streptokinase. So now we come to the second generation thrombolytic agents. You have anistreptase and alteplase. So anistreptase, from the name itself, it is actually a derivative of streptokinase. Okay, so it's a complex of purified plasminogen plus streptokinase. You have adding an acyl group to it to have enhanced pharmacokinetic property. So, in the body, this acyl group gets hydrolyzed. Once it is hydrolyzed, the activated streptokinase proactivated complex becomes free, and this modification gives it more fibrin specificity also. But since it contains streptokinase, this is also antigenic. This can also have allergic problems, just like that of streptokinase. Okay. So longer T half around 100 minutes. So this can be given as a single IV bolus also. Okay. All other features are similar to streptokinase. Now next, altiplase. So altiplase, retiplase, tenecteplase, all three of them belong to the group of recombinant tissue plasminogen activators, otherwise known as RTPA. Okay, so they are also called as RTPA. They are prepared by DNA technology, recombinant DNA technology. They have low affinity for free plasminogen. So they mainly activate the bound plasminogen. So what will be the advantage? The physiological clots will not get lysed. So the bleeding chance is less when compared with the earlier agents. Okay, it is highly fibrin specific. It hydrolyzes only fibrin, not fibrinogen, and it is superior to streptokinase and urokinase in hydrolyzing old clots. So what is the peculiarities about altiplase? One is it is derived from recombinant DNA technology. Another one is it has less affinity for the free plasminogen, highly fibrin specific, and it can hydrolyze old clots. Okay. Now, it has very short T-hub, around 4 to 8 minutes only. So, whenever you're giving altiplase, concurrently you have to give heparin to prevent the incidence of reocclusion. Okay. And adverse effects are similar to streptokinase. Mainly, you have bleeding as a side effect. But since it is derived from recombinant DNA technology, allergic reactions is not there. Antigenicity is not there. But around 10 times more expensive than that of streptokinase. If one vial of streptokinase is 2000, the altiplase the price is 20,000 for one vial. Okay. Now retiplase compared with altiplase, the T-half was slightly higher with a T-half of 15 to 20 minutes. For altiplase, it was 4 to 8 minutes. And tenecteplase, it's a genetically engineered mutant of altiplase. Higher fibrin specificity is there. More importantly, it has long T-half of 2 hours. So they can be given as bolus fibrinolytics, need not be given as an infusion. So even in a in a ambulance setting, you can give a shot of tenecteplase. Okay, can be injected as a single bolus dose. It is resistant to inhibition by antiplasmins and it is very expensive. Okay. What are the contraindications for fibrinolytics? You can divide the contraindications as absolute contraindications and relative contraindications. So you can think it is a fibrinolytic agent, it lyses the clot, there is increased risk of bleeding. So which all will be the contraindication for giving such an agent that lyses the clot? Okay, so if there is an intracranial hemorrhage or hemorrhagic stroke, you should not give this agent, that will worsen it, right? If there is an history of ischemic stroke in the past 1 year, there is chance of rebleeding or conversion of an ischemic stroke to hemorrhagic stroke if you give a thrombolytic agent. Uncontrolled hypertension, more than 180 millimeter of systolic BP or 110 millimeters of diastolic BP. If there is a suspicion of aortic dissection, if there is an active internal bleeding like GI bleeding, all these are absolute contraindications for fibrinolytics. What are relative contraindications? If you are on anticoagulants with the INR of more than 2, or if you are having any bleeding disorders, or if there is a recent surgical procedure you have done within 2 weeks, if you have done a prolonged CPR, known bleeding disorders, pregnancy, active peptic ulcer, controlled hypertension, all these are relative contraindications for fibrinolytics. Okay. Now, what are the uses of fibrinolytics? Where do we need to use these agents? You can think wherever there is a clot. What happens when there is a clot? In the myocardial blood vessels, you get myocardial infarction. And if there is a clot in the cerebral vessels, you get stroke. So these are the two main clinical conditions where we need to use thrombolytic therapy. Okay. So the first one is acute MI. The earlier, the best. Okay. At least you should try to give it within 12 hours of onset of MI. 3 to 6 hours is ideally the best time. If you are able to take the patient within 1 hour to the hospital and do this therapy, very good, because that can it can canalize the occluded blood vessels and can prevent the area of necrosis and can preserve the ventricular function. Okay. And we have already seen the early agents, streptokinase, urokinase and all cannot act on old clots. Okay. Then as I said, acute thrombotic stroke or acute ischemic stroke. In case of stroke, you should give the thrombolytic therapy within 3 hours. Okay. If it is more than 3 hours, there is chance of converting this ischemic stroke to hemorrhagic stroke. So that is why we are saying, if you are giving in case of ischemic stroke, try to give it within 3 hours. Okay. These are the two main indications. Then it is sometimes given in life-threatening deep vein thrombosis. Their anticoagulants have got a major role. Then if there is a very massive pulmonary embolism with hemodynamic instability, you may go for a thrombolytic therapy. And in case of acute arterial thrombosis, again thrombectomy is preferred. You try to surgically remove that thrombus, or you may go for thrombolytic therapy. So these are the clinical uses of fibrinolytics. Okay. Now, what are the guidelines for fibrinolytic agents? Which is the agent preferred? We prefer the newer recombinant tissue plasminogen activators like alteplase, reteplase, tenecteplase. Why? Because they are not antigenic, so no allergic reactions. They are more fibrin specific, so less chance of bleeding. And other advantages, tenecteplase and all can be given as a single bolus injection. Okay, may not be given as an infusion, but the main limiting factor is its cost. Timing, earlier the better. Acute myocardial infarction, give it within 12 hours. Stroke within 3 hours. Route, intravenous, either bolus or infusion. If it is long acting like tenecteplase, you can give it as a bolus injection. Main limitation is its cost. Have to give it as a continuous infusion case of streptokinase, urokinase or alteplase, and formation of antibodies in case of streptokinase or any streptase. Okay. So that is about the fibrinolytic agents. So if fibrinolytic is asked as a short note, what all will you write? First, you have to write about the examples. Remember the mnemonic surets: streptokinase, urokinase, reteplase, alteplase, anistreptase, and tenecteplase. What is the mechanism of action? It converts it activates tissue plasminogen activator, converts plasminogen to plasmin, which converts fibrin to fibrin degraded products. Then you briefly describe each of these fibrinolytic agents. Streptokinase, remember about derived from beta hemolytic streptococci, development of antibodies. It is antigenic, hence can produce allergic reactions, bleeding complications. Similarly, about urokinase, then regarding the recombinant tissue plasminogen activators, that is alteplase, tenecteplase, and reteplase. Okay. After that, you write the adverse effects, contraindications, relative contraindications, and absolute contraindications, and what are the clinical uses of fibrinolytics. Clinical uses, mainly you have acute myocardial infarction and acute ischemic or thrombotic stroke. Other uses includes DVT, massive pulmonary embolism, and arterial thromboembolism. Clear? Just a word about antifibrinolytics. How does antifibrinolytic act? By inhibiting the conversion of plasminogen to plasmin. Just the opposite is that of fibrinolytics. Okay. So, which converts, it blocks the conversion of plasminogen to plasmin. What are the examples? Three main examples are there. One is epsilon aminocaproic acid, otherwise known as EACA. Most frequently used agent is tranexamic acid, or the common brand names you've heard, Trapic and methanol. So that contains tranexamic acid. It is an analog of epsilon aminocaproic acid. It is more potent and longer acting than EACA. Other one is ectrotenin. Again, we can give it topically or as IV. It is a naturally occurring protease inhibitor. Now, where do we need to use as antifibrinolytics? Whenever there is a overdose of fibrinolytics or whenever there is fibrinolytic induced bleeding, you can definitely give antifibrinolytics. Which other situations can we give antifibrinolytics? Whenever there is increased chance of bleeding, like in case of menorrhagia or postpartum hemorrhage, after cardiac surgeries including CABG, bleeding peptic ulcer, following dental procedures like in case of hemophilia patients, after prostate surgery, tonsillectomy, epistasis. So these are all uses of anti-fibrinolytic agents. So that is regarding fibrinolytics and anti-fibrinolytics. It's a relatively easy topic. Hope you understood. Thank you.